welcome to everyone. Today we are beginning the year. Happy New Year 2021 to every person. We are starting our first webinar series, which is a symposium on traumatic brain injury. And as you all know, traumatic brain injury is a public health problem of global health concern and accounts for a very significant cost for disability, death, and patients and families affected by this have to spend a lot to manage this condition. So that's why today we decided to choose the theme TBI in Africa, a silent pandemic, because the data on TBI from Africa is unfortunately very scanty, and we intend to change this in the coming years. Without much ado, I'm going to call on the president of the Continental Association of African Neurosurgical Societies, Mr. Mahmoud Korashi, to open up the session.
Thank you very much, Ignatius. It's a pleasure to be part of this exciting Young CANS Neurosurgeons webinar. I really do appreciate the presence of Professor Franco Servadei, the president of the WFNS, and in his capacity both as president and also because he is one of the leading figures globally on traumatic brain injuries. So thank you very much, Professor Servadei. And I also am very grateful for all the speakers who have really taken their time. And we also have faculty in Professor Anthony Figaji from South Africa. We've got Kee Park, member of the WFNS Global Committee. So I will ask the moderator to officially invite Professor Servadei to the meeting. So Dr. Laeke, please, yours. Thank you very much for having us.
Thank you very much.
Thank you so much, Professor Korashi. Yeah, Segaya, just before we proceed, I would just like to acknowledge a few people who have really contributed to the success of this symposium. So we have, we fully thank the president of CANS and the entire CANS AC for supporting the activities of the Young African Neurosurgeons. And then we have Kobile and Beverly who have been running and preparing this webinar. So today we have Chidi. Chidi, you see the very beautiful flyers. He's the one who actually designed them. And then you have Sega, who is going to be moderating the session today. So this is our email address. If you want to get in touch with us, you can send us an email to youngcans@gmail.com or the Young African Neurosurgeons@gmail.com. You can follow us on Facebook, Twitter, and this a Telegram link. Kobile, you can maybe give a rundown of the program.
Thank you, and welcome to everyone. So today is almost a marathon session, so it is fluid. I know a lot of the audience will be moving in and out between the various sessions. Each sessions with the chairpersons are 45 minutes, and at the end of the session, please put your Q&As in the box so they can be posed to both the speakers and also the chairpersons of the session. Welcome to everyone. We've had an overwhelming number of people register, close to 500. So it's really, really exciting. And also to the speakers today that we've gotten to meet during the week. You're welcome. We're very proud of the work you're about to present. And just to give a bit of context, all the speakers that are presenting today actually had sessions with the committee to show their presentations, and a lot of hard work has been invested in putting on a good show for everyone today. So before we get started, I would like to start off by introducing our moderator for the session. Okay, so our moderator for the session is Associate Professor Tsegazeab. So he's a neurosurgeon in Addis Ababa. He's also a fellow of the College of Southeast and Central Africa. He's secretary of the Society of Ethiopian Neurological Surgery Professionals. And he's done a lot of work in putting together this program today. So he's going to be moving in between introducing all the speakers, and it's a great pleasure to hand over to him.
Thank you, Kobile. So we will start with the first presentation. First, I would like to thank Professor Franco for taking your time and joining on this important occasion. So the first topic will be evidence-based guidelines in traumatic brain injury. So Professor Franco will be talking about evidence-based guidelines in TBI. So I'd like to thank Professor Franco, and I'll give the floor to Professor Franco. Thank you very much.
Hello, everyone. I think, okay, happy to be here with you. Ignatius invited me a couple of months ago, and I think education via web for young neurosurgeon is one of the few positive aspects of this terrible pandemic. We learned that we can teach and discuss via web. We don't need long travel. We don't need expenses. We can exchange our opinions. We can listen to lecturers. We can work together. And except for thinking only about education, we think also about a community of young and older and senior neurosurgeons who is just working together to get the best management for the patients, especially in countries like in Africa where the facilities are limited. So I will target my presentation about how can we work with evidence-based guidelines. This is, okay. We do have to follow evidence-based guidelines, but how can we do it in the different parts of the world, and which are the limits of the evidence-based guidelines? All of you know that we had about 96, is 25 years ago, the first set of guidelines published by our American colleagues. And some European, I was part of the group who was working on the guidelines by the Brain Trauma Foundation and the American Association. We all learned how can we do an evidence-based guidelines. We need to review all the evidence-based papers published, grade them in 3 levels, class 1, 2, and 3. And obviously the class 1 are the best, the prospective randomized control trial. The class 3 are the worst, only anecdotal cases and single series. If we put together the level of evidence, class 1 and 2, we can define standards, guidelines, and options. Standard means, in practical terms, something that we all have to do because we have clear proof that it works. Guidelines is less, and options are even less. There have been many editions of the American guidelines. This is the last one, which was published in 2017, and contains about 18 topics. 14 of these were renewed as compared to the previous sessions, the previous publications. I have just marked quite a few things like how to do a craniectomy, it should be large, or if hypothermia is not recommended, we can use external ventricular drainage. We can manage your patients with information from intracranial pressure monitoring, and we can also manage our patient by following cerebral perfusion pressure. There is something completely new in the last set of guidelines. These guidelines will be followed by addendum, by something adding on the way. And this is the addendum, which was just published about decompressive craniectomy. In this addendum, there is one sentence which is entirely new and is mostly important for the young fellows who are following us. The addendum says that to increase the utility of recommendation, there is a new section called incorporating the evidence into practice. This is extremely important. Not only evidence-based medicine, but how evidence-based medicine is incorporated into practice. So what about the critical lectures? So we have to follow their guidelines. We have the guidelines, you can see them on the web. How do we have to read the guidelines? First limit is the amount of class 1 papers which were published, very few. You see in this article, we are talking about neurosurgery, not only neurotrauma, but if you look at the arrows, traumatic brain injury, the number of class 1 paper is very limited, and in some circumstances is almost non-existing. So we have to consider that our recommendations are not solidly based. The second, evidence-based guidelines can be contradicted by subsequent papers. They are not written in stone like the Bible, which cannot be changed, but they can be changed. I say we because I was one of the authors. We made a mistake. In the first version of the guidelines, we say that we should keep cerebral perfusion pressure above 70 millimeter of mercury. This was wrong. Many papers proved subsequently that we are increasing the risk of an adult respiratory distress syndrome, showed we should keep it lower, between 50 and 70. Or we see it here, we have to know that many very good published papers were controversial within a few years, let's say. So we have to think about evidence-based medicine is changing day by day, year by year. Third, obvious treatments do not need the clinical trials. Nobody is going to do a clinical trial for something which is obvious. This is particularly important in surgery, in any field of neurosurgery. So when I was one of the authors again, published the guidelines for surgical management, we only found class 3 papers. So we found papers of very low quality. Why? Because, you know, this patient with an acute epidural in the posterior fascia is not going to be randomized into a group of patients who can be operated and someone who is not going to be operated. So even if ranking evacuation of surgery of large post-traumatic hematoma as option is in accordance with evidence-based medicine, is not obviously in accordance with our practice. So we have to balance between evidence-based and practice. Then a mistake which was done is controlling the application of the guidelines with only one parameter, which basically was the rate of ICP monitoring, which may probably, I'm not sure about it, it may work in Europe and the United States or Canada or wherever, but it cannot work in countries with limited facilities where ICP monitoring is not a routine. So we cannot say that someone has not applied the guidelines because has not inserted an ICP monitoring. And as you see, there were quite a number of patients asking a change. And you see that it cannot, the accomplishment of the guidelines cannot be based only upon one parameter, ICP monitoring. The fifth and the most important let's say, discussion that we have now, which is pertinent to you in Africa, is clearly the one you see it now. The papers, high quality papers, randomized clinical trial is done in one part of the world. Trauma are in the other part of the world. So as you see it here, if we look at guidelines, evidence-based, there is only one middle-level country, not low, middle, Brazil. All the others are high-quality, high-income countries. So only one part of the world is publishing guidelines. And as you see it here, they are done by high-income countries for high-income countries. These are American, UK, Italian, all these guidelines are made in one part of the world. And also the research, you see these, the two most important comprehensive craniectomy trials, you see that almost all of them have included only patients from high-income countries. But if we look at the map, which has been published by the group of Kee Park, who is here with us, concerning the incidence of traumatic brain injury from road traffic collision, you see that they are located in South America, Africa, Southeast Asia, you see these areas. But if we look at the number of papers published, they all are located in Europe, America, some in China, Japan, you see it here. So the publications are here and the trauma are here. So there are two parts of the world. We have published recently a paper on neurosurgical focus, and you see it here, the incidence of trauma versus publication. And you see that in America, this is the incidence, these are the publication. In Europe, a bit less, but even more. This is Africa. This is the incidence of trauma, and these are the publications related to trauma. So which are the suggestions for future? You see it here. We need guidelines based on evidence, obviously, but also on clinical utility. And we have now found a way, you will see, to combine clinical utility and guidelines. This is what I told you before. If you read the addendum to the American guidelines, you can see it here. You see that they have added an impact of evidence on practice. So we need to know how much of the guidelines that we write and publish is going to the clinical practice, especially in countries like Africa. So what we have tried as WFNS and many others is to organize consensus conference, where you see in the consensus conference, you can include neurosurgeons from India, Indonesia, Pakistan, Ethiopia, Vietnam, Tanzania, Uganda, South Africa, from everywhere. So the consensus conference, differently from evidence-based, is including many. These are slides that I have taken from my friend Randy Chesram, and you see that there are also in America at very high level consensus-based conference. So even our American colleagues have shifted from evidence-based guidelines to consensus conference. Why consensus conference? Because we don't need evidence-based medicine. It's a mixture with also expert opinion. And this is a statement about decompressive craniectomy in low middle income countries, in spite of limited publication, but we can do something. We can suggest some management. So again, from Randy, you can, what do you do with consensus recommendation or guidelines? You can ignore them, you can adopt them, and you can adapt them. We think, all of us, we think that adaptation is the most important. So we do have to follow the guidelines. We have to keep in mind the limit of the process, as I told you. we need a strong collaboration between us and you, between the Western institutions and those one located in low and middle income countries like Africa. We need to work together to adapt the evidence-based medicine to the local facilities and environment. And these are all the institutions, the continental, the World Federation, the Americans, the Europeans, the CAMS, the South Americans. We all are trying to work together. And I hope today we can have an example of how do we do it. Thank you.
Thank you very much, Professor Franco. It was a very enlightening presentation. So in the meantime, if participants have any questions, you can forward it to the chat box. So we'll continue to the next presentation. The next presentation will be by Dr. Likuya Monka. So he will be presenting on predictors of hospital outcomes of patients with penetrating craniocerebral injuries in armed conflict areas of the Democratic Republic of Congo. It's a retrospective series, so I'll give the floor to Professor Laeke.
I'm a resident, co-6 resident in neurosurgery. I'm based in Uganda. I'm from DRC. I'm going to present our article. Those are the authors. I'm going to present on behalf of all the authors, Dr. Safari, and we have also Dr. Murula, who are also there following us, and we are from different affiliation. So from the introduction, I would like to introduce that penetrating craniocerebral injuries are a type of open injury caused by a sharp object or missiles resulting in communication between the cranial cavity and the external environment. As we can see that illustration pictures, you can see from the skin to the brain, there's a bridge which is going to communicate in between. Usually, when we're talking about penetrating, the sharp object doesn't exist or remain stuck into the cranial cavity. This condition is deemed to be more prevalent in armed conflict region, where both civilian and military are frequently assaulted over the head. But as Professor Servadei have just mentioned it, reporting about what is happening in low-income countries, especially in where we don't have data, we don't know what is exactly happening, and especially the hospital outcome. I just put a picture here. You can see this is just a scenario. It's not part of the research, just to make us understand why we conducted this study, because they put a map of DRC around. You can see some hot zone with in the eastern part of DRC. Like it's over more than 20 years. This part is involved in conflict army for many years. And we have quite a number of victims who used to come and be referred to the hospital where we did that study, which is located just in the middle. So we wanted to see identify the predictors of poor outcome among patients. So as we say, it's a retrospective study. We wanted to see how many patients who had poor outcome and what was the predictors to have those poor outcome. And we defined poor outcome when the Glasgow outcome scale was below 4. This is a summary of the presentation of the demographic. We can see, as I'm showing here, most of them were civilian who've been assaulted. And if you look at also the hemodynamic instability, there were quite a big number who had poor outcome, having this instability in the beginning. So this is some of the picture of patient just put just to illustrate what we usually have in the brain CT scan. They present in different. We can have kind of penetrating with underlying brain contusion and hemorrhage inside. or we may have in-driven fragments, such as depressed skull fractures and different features. And clinically, sometimes we have those are also so different patients. Just to illustrate, we may have a very tiny wound that you can actually see. Obviously, nothing. Usually, like a bullet is just lodged inside, and sometimes it's quite obvious with a track, or we have sometimes entry and exit wound, and obviously intraoperatively used to find a cracked bone or fractures. So our study, we found out that admission GCS and neurological deficit, especially when they come with the hemiparesis or hemiparesia, they have poor outcome with regards statistical difference. But also, when we look at the intracranial bleeding, this is like including everything like contusion or subdural and everything. We just put them in the whole box to call them intracranial bleeding. They kind of having a poor outcome. Of course, as limitation, we say this study was retrospective, so there's a lot of confounders, and also some of the parameters we didn't look at because the files couldn't capture many. So to conclude, I would like to share this case. Just I'm going to do quickly. This is the article shows us that admission GCS, intracerebral hemorrhage, and hemiparesis, these are very simple parameters that we can capture to detect this patient who are going to have a poor outcome among open injuries in conflict region. So we advocate to optimize the initial care when the patient they are coming where there is almost no one to care for them. So I don't know, I'm having very few minutes. I'm going to present this one quickly. This is a case of a patient, 50 years old, shot with a machete over the head by unknown people. He was referred 2 days ago. Initially lost consciousness. He has a laceration done in the small peripheral clinic and then referred to us. He was pale. And this is the wound, how it looks like when he came. GCS was 11, he was aphasic, he has a hemiparesis. That was a hemostatic suture done before they referred to us. So when we investigate the patient, this is what we found, kind of left hemisphere and right hemisphere edema with a domain fragment in the infected region. So this is the other picture of the patient in the bone window. It is almost bilateral, but the most obvious was in the right. So we diagnosed over corneal secondary.
Sorry, Dr. Rukuya, you are left with 2 minutes.
Thank you. So as to go to the management of the case, so we did pre-op antibiotic therapy, analgesia, osmotherapy, and also anticonvulsant, and also blood transfusion. So this patient, with time, he kind of deteriorating. We decided to do a decompressive craniectomy and debride and do the duroplasty for blood transfusion. Post-op, the patient did well, although he remained aphasic, and there was discharge day 7 and review several times in the OPD. I think I can stop my presentation here. Thank you.
Thank you very much, Dr. Likoya. So we'll be proceeding to the next presentation. The next presentation is by Dr. Bankole. Dr. Bankole is a candidate neurosurgeon, neurosurgery resident at Morocco, the WFNS training center. So he will be presenting on decompressive craniectomy for severe TBI in LMICs, when, who, and why. It's a cohort retrospective study. So kindly you can proceed sharing your screen, Dr. Bankole.
Thank you so much. I hope you everyone is hearing. Can you see my screen?
Yes, it's visible.
Okay, thank you very much. I will present today the compressive craniectomy for severe TBI in LIC and LMIC. This will be my plan, introduction, method, result, and discussion, and to conclude. We all know that medical management, like first line to fight against elevated ICP due to severe TBI and LMIC, is still precarious, especially with the lack of means for adequate monitoring of intracranial pressure. The compressive craniectomy is a surgical option to manage elevated ICP that is refractory to medical treatment. The place of transcranial Doppler in the management of all severe traumatic brain injury remains today important in the therapeutic decision-making to perform the compressive craniectomy in the area where we did not have the means to perform monitoring of intracranial pressure. The aim of this study is to show if transcranial Doppler could have an impact of decision-making to operate with the Glasgow outcome scale of patients in the case where we do not have ICP, and to highlight how the age and the Glasgow coma scale influenced the Glasgow outcome scale. That is our method. It was a cohort retrospective comparative study. We collected retrospectively our data from March 2017 to July 2019. We collected the Glasgow coma scale for age, sex, and Glasgow outcome scale, and for comparative purpose, we stratify our cohort by a group of patients with transcranial Doppler and a group of patients with no transcranial Doppler. We use the Wilcoxon sign rank test and the relative sample Friedman ANOVA by ranks. The threshold of statistical significance was set at 0.05. So that's our data collection. That you can see the demographic characteristic, the Glasgow coma scale before the compressive craniectomy, the Glasgow outcome scale at discharge, and we have two groups before and after the compressive craniectomy where we use transcranial Doppler and no transcranial Doppler before and after the craniectomy in the second group. So that is our result. We have 71 cases were included. Transcranial Doppler was performed in 73.2% of our patients and 26.8%.
Okay, it appears that we have lost Bankoli. So, Tsegazeab, I think we can move on to the next speaker.
Yeah, sorry for that. So we should proceed on to the next presentation. The next presentation is by Dr. Chinwendu from Nigeria. So he will be presenting on a case of a large middle cranial fossa. So Dr. Chinwendu is going to present on a large middle cranial fossa cyst discovered post-traumatic brain injury. It's a clinical case. So you can start screen sharing, Dr. Chinwendu.
Hello, good evening. I'm Dr. Chinwendu Mebemiro from Nigeria. I'm a second-year resident in surgery department in the Federal Medical Center, Umuahia. I'll be presenting a clinical case of a large middle cranial fossa cyst discovered post-traumatic brain injury. And this will be my outline. The middle cranial fossa cysts are primarily arachnoid cysts. They're usually developmental lesions, and they constitute about 1% of intracranial space-occupying lesions. They're usually clinically quiet, and usually incidentally discovered on neuroimaging. When they are symptomatic, the most common symptom is headache, and others may include seizures, nausea, ataxia, limb weakness, psychosis, or hydrocephalus. The symptoms are usually related to the cyst, increase in cyst enlargement, and the pressure effect or usually they can also be sudden from rapid intracranial decompression following minor head trauma. The patient was a 20-year-old male that was referred to our hospital from a private facility on the 20th of December 2020. He fell from a 5-meter height, about 2 stories, 2 days prior, and immediately lost consciousness. He developed frequent seizures characterized by jerking of the right upper and lower limbs. There were no open wounds, no effusions from the craniofacial orifices, and no vomiting. Prior to the incident, he was okay. There were no symptoms. His Glasgow coma scale on presentation to a facility of 3. He was in respiratory distress, had decreased left breath sounds on the left, and also observed the left-sided paralysis. Chest X-ray was done that showed left pneumothorax, for which he had a tip thoracostomy. And then the CT scan, cranial cervical CT was done that showed no findings related to trauma. However, we noticed a large middle fossa arachnoid cyst with midline shifts and evidence of long-standing pressure effects on the bone. It's shown by the arrows here. He was nursed in the ICU for severe head injury, and the next day we did a cystoperitoneal shunt with a low pressure valve for him. Intraoperatively, the cyst was noted to be clear and under pressure. He made a slow but steady improvement, and the seizures have completely resolved. These are the post-operative imaging. Reports on symptomatic arachnoid cysts following trauma have mostly been in association with minor head injury. The effects of trauma that have been implicated in the clinical decompensation of patients with arachnoid cysts include a rise in intracranial pressure, sudden rise in intracranial pressure, cyst rupture, and cyst-related hemorrhage, intracystic hemorrhage or subdural hemorrhage. The patients we representing had a Galaxy 3 middle fossa cyst that was discovered during evaluation for severe head injury. The CT scan showed evidence of long-standing pressure on bone and significant midline shift. However, we didn't find any findings in the CT that was related to trauma as the cause of his clinical state, and there are no trauma-related cyst changes. The consensus for management of large symptomatic cysts is surgery. Options include microsurgical craniotomy, endoscopic procedures, cystocystinostomy, cystoventriculostomy. If people have tried stereotactic aspiration, but that also comes with increased chances of reaccumulation. And then cystoperitoneal shunting. Internal shunting to the subdural space has also been reported by a few. So cystoperitoneal shunting has been preferred in patients with large cysts to prevent over-drainage and fierce variation in intracranial pressure. And most reports show a favorable outcome. Our patient had this cystoperitoneal shunting for his own cyst. We present this report to highlight the possibilities of an intracranial decompensation in patients with prior undiagnosed large arachnoid cysts who have head injury, with or without any trauma-related cyst changes or imaging findings related to trauma. We've not had any.
You have 2 minutes left. Thank you.
Okay, thank you very much, sir. We've not found any reports highlighting the clinical cause of patients presenting in this manner. These are my references. Thank you very much.
Thank you very much, Dr. Chinwendu.
So please,
go on.
Please, can I come back to my presentation? I don't know what happened.
Yeah, sure. You can now present if you are back with your internet connection.
So, in order to evaluate if in order to evaluate if the transcranial Doppler could have an impact on decision making to go for decompressive craniotomy and influence the Glasgow outcome scale, PESTEL revealed statistically significantly positive in the using of a transcranial Doppler for severe TBI with p-value less than 0.001 with a median effect OER equal to 0.23. PER test revealed also a significant effect of age activity and the Glasgow coma scale less than 5 of patients before decompressive craniotomy with a poor Glasgow outcome scale like Dave with p-value less than 0.001. Daniel Ziegler reported that transcranial Doppler is useful in patients with severe TBI and helpful in predicting outcome and management. They reported that for patients with normal measurement, over 80% can expect a good outcome. Patients with hypoperfusion measurement have a high mortality with 90% dying from brain diff. Even patients with hypoperfusion measurement that normalize have a significant mortality of 44%, and patients with vasospasm measurement have an increased mortality. In our study, the transcranial Doppler data found 88% of increase in intracranial pressure correlated by increase of IP and less of pulsatility, with average IP, the mean IP was 3 with a standard deviation range of 2 and 6, and decrease of velocity with mean 22 with standard range 80 for 44. Transcranial Doppler monitoring of patients with TBI can be used to reveal various pathologic hemodynamic change. Tao Cheng et al. Reported in their study that the ICP combined with transcranial Doppler monitoring group showed a higher frequency of patients with favorable outcome compared with the routine ICP monitoring group. In our series, transcranial Doppler was performed in 73%. ICP monitoring is the gold standard of the management, but in LIC or LMIC, with a lack of ICP monitoring, transcranial Doppler could be a great alternative. Ramazan Sari reported that transcranial Doppler as a real-time monitor may help for an early decision of surgical approach in the management of TBI patients. So the best time to decompress a patient is still under discussion, but early decompression recommended for severely head-injured patients without brainstem dysfunction, requiring neurosurgery for removing intracranial collection. In addition, data suggested that complication of TBI might reduce following early decompressive craniectomy at the end of the 20th century.
You are left with 1 minute.
Okay. So we go to did my suggestion. We have to take it like a guideline in Africa, where we are not able to use ICP monitoring, and transcranial Doppler could help to achieve the same goals to manage ICP. Auto-related a rapid brain relaxation open the system opening and a progressive improvement of the neurological condition in the following hours to date. Many cases were treated by cystostomy with satisfactory result. That's our limitation. I will go to conclude. Severe TBI should be managed like the guideline in literature. However, depend on the mean and the area like LIC and LMIC, we should take into consideration our context and adapt our management. And transcranial Doppler regain its place in decision making and the Glasgow outcome scale, the age, the Glasgow coma scale before the compressive craniectomy influenced a lot the Glasgow outcome scale. So thank you very much. I finished. Thank you.
Thank you very much, Bankole. So the next presentation will be by Kobile. So Ignatius will introduce Kobile.
Well, thank you so much. It's an honor for me to present Kobile. Kobile is an active member of the Young African Neurosurgeon Forum. And a few weeks back, he just completed a fellowship in pediatric neurosurgery at the Red Cross Children's Hospital in Cape Town, South Africa. And concomitantly, she picked up a position as a lecturer of neurosurgery in the same institution. She's a member of the WFNS Young Neurosurgeon Forum. And Kobile, we are very proud of you. Congratulations for your achievement. So you have the floor now to give us your presentation on your research on TBI.
Ignatius, thank you so much for your kind words. I'm just going to start.
In the US, mainly by US, at least 1/3 of them are anesthesiologists and intensivists. So there is a strong contribution of anesthesiologists and intensive. They are not only done by neurosurgeons. Most of them are concerning management of severely injured patients. So it means in operating theater, in ICU. I believe personally that a strong collaboration with anesthesiologists is the most important part of our work. So yes, the answer is yes.
Okay. Thank you, Prof. Franco. So the other question is so that's a question about why consensus recommendations are not the best approach and what are recommendations for optional situations.
Well, that is a long question, long discussion, but I make it simple. Evidence-based medicine is important and is done by published papers, level 1, level 2, and so on. Consensus conference is not only based on papers published, but also based on experience. For instance, you have been with us in, many of you have been with us in Cambridge for the decompression craniectomy consensus. And each statement, when to operate, let's say, when to decompress a patient with raised pressure, was discussed looking at the paper published, but also looking at the experience of the panelists. So the consensus conference is a mixture between evidence-based and experience. It's not purely based on evidence-based medicine. And this, in a way, it's in conflict with the purity of the process of guidelines. But we are trying to work on this.
Thank you, Prof. Franco. There is another question for Kobile. So did glycerol rise also correlate clinically with deterioration?
Sorry, can you repeat the question? Is it the one I'm reading? What is the dose for glycerol you use? Is that from Janabe Ba? Is that the question?
Yeah, it says, did glycerol rise also correlate clinically with the deterioration of patients?
So I think by deterioration, I'm assuming they're meaning outcome. So that was shown on our line graph that I showed. So there wasn't really a strong correlation between raised glycerol levels and outcome. And on that graph, we could see between day 1 and 2, it almost looked like the group that did unwell with an unfavorable outcome had elevated levels. But by day 3 and 4, it wasn't really comparable. So no, we couldn't associate it with outcome particularly. Our study associated with lesion progression on scans. Okay.
Okay. Thank you, Kobile. So the other question is for Dr. Nuru. So what could you map out the main difficulties? What are the challenges for setup like a low and middle income countries to carry out ventricular or intraparenchymal monitoring?
Thank you, Dr. Laeke. Thank you, Natalie, for your question. That is the big challenge that we encountered in our practice in LIC and LMIC. We don't have means to. We didn't have that in our hospital. We don't have. It is a lot of problem that we encountered. We didn't have ICP monitoring. That is why we think that we should use a transcranial Doppler to try to take a decision, to go to making a decision, and after decompressing anatomy to try to continue our monitoring with Doppler to see what is going on our outcome after surgery. It is very difficult to find monitoring in LICs and LMIC. We didn't have the means. That is the problem. So it is our policy who should do the effort to make it to try. They have to do their best to update the technique. I don't know how can I say that. Everything that we should do to take care about our patient with TBI in LICs and LMICs.
Thank you, Dr. Nuru. So, yeah, Prof. Franco.
Well, if I can comment, this is a very common question about how can we get the ICP monitoring. When we talk about decompression, we have to remember that we have two types of decompression. The primary decompression is done with hematoma evacuation. For instance, I take out a subdural hematoma and I decompress the patient. There we don't need any ICP monitoring. It's done in emergency. So even in Europe, we don't have any monitoring. Maybe post-op, but before surgery in primary decompression, there is no monitoring. The monitoring is helpful when you have a patient who is stable, maybe intubated in ICU, and you want to decide later if you cannot treat increasing ICP. As far as I see from papers published in Africa and many low-income countries, this is not the commonest situation. The commonest situation is when you can decide based on CT scan and emergency evacuation of something. So this is a problem only for a small subset of patients. We have to remember these are patients that are important, but they are not all the patients where we do decompression. In a large group of patients, we don't need it. We need only for those ones who are admitted with high intracranial pressure.
Yes.
Yeah, thank you, Prof. Franco. So with the interest of time, we will proceed to the next session. The next session will be research priorities in neurotrauma. So Dr. Kobile will introduce Prof. Figaji.
Thank you, Tsegazeab. So it gives me a great honor to introduce Professor Figaji. Not only is he my boss, Professor Figaji is a surgeon scientist, and he's professor and head of pediatric neurosurgery at the University of Cape Town. He holds many caps, specifically as a South African National Research Foundation chair of clinical neurosciences, and he is the only surgeon in the country to hold this position. He's also secretary of the ISPN, and he is also the scientific chair for the WFNS 2023. The list is long, so I chose top 3. On top of that, he's a mentor to a lot of young neurosurgeons, because he has the ability to not only be an excellent surgeon within theatre and still actively involved in training his fellows and operating on patients, but he's also had a great influence within the scientific community. It is our pleasure to have you, Prof, and we're handing over to you for your session.
Thanks very much. Well, I don't know who you were talking about, but he sounds great. So I will. Thank you for the invitation first. I think I only got the invitation because I'm Mobile's boss. But I want to talk about something perhaps that will cause a little bit of controversy. My talk will be relatively light on data, but heavier on concepts and ideas. I wanted to speak to the challenges and opportunities for TBI research in Africa, but in doing so, to look at some of the hard truths that we must face. So as such, I'm absolutely certain that I'll offend someone. And if it's you that I offend, I apologize in advance, but please take comfort in the fact that if there's anything that I believe in, it's equality. So the chances are pretty good that I will offend everyone, including myself. Wouldn't be right to leave anyone out. My first point is this: there is enormous potential for TBI to make a difference in TBI clinical work and research in Africa and affect the rest of the world. TBI research in Africa and from Africa. Now, for me, when I look back on my career, and I don't think I'm unique. I think all of us have opportunities to do this, but I've seen how one can start from scratch and slowly build on to have a local impact and regional impact, and then an international impact. So this is where I work. I work at a children's hospital and at our recently launched Neurosciences Institute. So I started our unit for TBI research from scratch about 15 years ago. And we've created what I think is a very good ICU environment that is very unusual for children anywhere in the world. And in that time, we've been able to develop some interesting insights in the way that we manage children with severe TBI, especially with advanced monitoring. And along the way, I became president of the International Neurotrauma Society, and then now recently pediatric lead of the Brain Trauma Foundation. But the question is, why is that an unusual story? That should be a usual story for us in Africa, but it isn't. So to kick off that discussion, I want to reference an article that Professor Servadei already referenced, a great article that makes the point very clearly that TBI is more common in low and middle income countries. But despite that, an extremely small percentage of their work in TBI research comes from low and middle income countries in general, and Africa in particular. But ironically, of course, the authors of the paper themselves come from high income countries. And that's not something that I want to criticize, because I know these authors, and they're extremely committed to making a real difference in Africa, at least low and middle income country TBI research in general, no question. But it is ironically emblematic of the broader problem. Now, if you look at their data, a measly 1% of research comes from Africa, the continent that arguably has a higher TBI per capita rate than any of the other continents. So my personal experience reflects a little bit of this because it's been an uphill battle, and I've had to face hurdles that I think that probably my peers in the global north haven't had to face. But clearly it's still possible to make progress, right? But why is it not more common a story in Africa? It's easy to dismiss this as an uncommon story, and people explain it. There's something about me, there's something about my unit or the hospital, the university. But I don't think so. I believe that the opportunity is there for all of us, but clearly there are barriers in our way. When I think of those barriers, I like to think of it as a border wall to TBI research from low and middle income countries. So some of you may recognize this. This is the so-called border wall between US and Mexico that the previous US administration promised to build and get Mexico to fund it. Well, they did partially build it, but they funded it themselves. And everybody knows about this border wall. So it took up a huge amount of news space over the last 4 years, and everybody all across the world knows about the border wall between the US and Mexico. And I would argue that far more than what I would argue, with no disrespect to the people affected by the wall, are the walls to progress in healthcare and research in between high-income countries and low and middle-income countries. Much bigger issue globally across the world. It affects a larger proportion of the world's population, and yet we know about this border wall, and we don't consider the barriers to TBI research. So over the years, I've been thinking about these barriers, and I've come up with 3 categories. One category is the environment in which we work in. The other category is the problem with researchers in high-income countries. And the third category is the problem with researchers in low and middle-income countries. So let me start with the environment. So one of the biggest problems in our environment is A, that there's a need, B, that the hospitals that are there to support us in research and the universities that are there to support us in research don't support us. The funders for research, both locally as well as internationally, they're not particularly interested in TBI research, interested in HIV and TB research and malaria in Africa. They're not interested in TBI. So we have a large burden of disease as clinicians we're trying to manage, but we have no time for research. For those who are full-time researchers, they can't get funded for TBI research, so they go into infectious diseases. The costs of research are often prohibitive. We don't have an infrastructure for research. We don't have any direct funding. So those are the problems that are associated with the hospital as manifest by our local environment, our hospital, at least our overall environment as manifest by the cities that we work in, our hospitals, our universities, and our funders. So if you look at the Bill and Melinda Gates Foundation, a huge amount of money that they give to Africa, the vast amount of that money is in infectious diseases. If you look at the Fogarty International Center or other branches of the NIH that are associated with funding research outside of the US, again, there's an overwhelming predominance of HIV and TB research. And then when you look at journals, I think that, and this may be a little bit more controversial, but it would be nice, but naive to think that there's equity or equal opportunity in publishing. We like to think that publishing is blind, but is affected by all sorts of factors, interest groups, finances, and networking. There's a huge amount of bias, explicit and implicit, in how we get articles published. So that's our environment. What about as I said, what are the things that I would consider the problems with researchers from high-income countries? And now it may get a little bit more uncomfortable. Global neurosurgery has exploded over the last 5 to 10 years. And a lot of that global neurosurgery is good for low and middle income countries, but I think for many, it's an excuse to build their careers in institutions from high income countries. Sometimes it's driven by a neo-colonial mindset. And in the past, people came to Africa to mine their mineral wealth. Now it's data that is being mined in Africa. Sometimes there are very well-meaning attempts but there's no sustainability built into the program. So when the project is done, the center goes back to what they were before the program started. I find that there are lots of researchers from high-income countries speaking on behalf of researchers in low and middle-income countries to large organizations like the WHO and big funders. Very often there's a global north agenda, although the problems are global south problems. And then, as Professor Servadei mentioned, when guidelines are developed, they're often very focused on high-income countries, whereas the majority of TBI occurs in low and middle-income countries. And the authors of those guidelines are almost always from high-income countries, with the exception of, I think, a few outstanding groups, like the group that Professor Servadei mentioned with decompressive craniectomy, a wonderfully constituted group of researchers and those who have investment in the problem from high and low income countries. In general, if it gets published out of the US, the vast majority of authors are going to be US based. But what about the problems with researchers from low and middle income countries? Well, very often we lack research skills. Sometimes we lack motivation for research. And very often students at university, and then they graduate, they have to specialize in surgery, and then neurosurgery takes a long time, spent a lot of money, and they have to be for the rest of their career motivated by making money. And you can't make money in research. For some people, it's an escape from Africa. They want to build their careers. They want to get into a unit somewhere else and leave Africa behind. Some people have the view that TBI research isn't real neurosurgery. So if you're interested in TBI, you're not a real neurosurgeon, the type of neurosurgeon that operates on vascular diseases and tumors in the brain. And then we have to ask ourselves, what constitutes good quality research? And in my experience, probably about 10 years ago now, I remember going to one of the infectious diseases colleagues who had an incredible research track record, and we were asking them advice on how to build our unit, and he was completely dismissive of the typical approach in surgery, which we've all seen and which we all do. He says retrospective research, the case series, that's not research. And it was quite hard to take, of course, because that's where we were at. But and he didn't mean to be offensive, but the message that he was trying to communicate was that if you want to do research, you have to be organized. You have to create an infrastructure. You have to start with prospective questions that you'll develop a methodology to try to answer. That's proper research. And then very lastly, very often in Africa, we are plagued with a poverty, what I call a poverty and a disadvantage mindset. So we speak of ourselves as poor people from Africa who are disadvantaged, and that of course is true, but it doesn't have to be a hurdle to our progress, and that or a hurdle to our motivation either. But so those are all the problems, but I'm not a harsh guy, and I don't think I'm a pessimist. There's always a silver lining, and there are just incredible opportunities in Africa. A, because you've got this massive burden of disease. And because we see a lot of patients, we develop clinical expertise and insights that very often our colleagues in North America and Western Europe don't develop because they don't see the same number of patients we do. Clinical trials are feasible in Africa because of numbers. So if you want to do a clinical trial, it doesn't make sense funding it in Western Europe or North America, because in Africa or other low and middle income countries, you can do a trial in 1 or 2 years that would take 5 or 10 years in a Western European environment, and it's more generalizable, the findings of that trial, to the places where TBI really occurs. And then, of course, we have all access to biological samples if we're interested in the mechanistic aspects of disease. So there are great opportunities. And I think as we've shown in our unit, we can develop the infrastructure and skills to produce high quality research that makes a difference to patients and has an impact on the world beyond our borders. And we've slowly done that over time. And from an African context, it may be surprising, but we rely heavily on advanced monitoring, which is possible in our environment. We can mentor and train in Africa. We don't have to send promising surgeons and neurosurgeons overseas to develop the skills. Increasingly, they can stay on the African continent, we can retain them, and they can develop high-level clinical skills, and they can develop their careers. And then lastly, for lab-based researchers, we can develop really good infrastructures to support research, develop clinical and research skills, and decrease outsourcing or our dependence on labs in North America and Western Europe. It is possible. How is that possible? I think there are several hard questions we have to ask in those three categories. So, of our environment, is it supporting meaningful research aligned with our local priorities? And are they proportional to burden of disease? Is our collaboration investing in local skills and infrastructure? Are we building sustainability in that? If we have a collaboration with the North American or Western European collaborator, who benefits most from that collaboration? And then finally, can we challenge journals and funders to reset their mind about how they view researchers in low and middle income countries? Questions to ask researchers from high income countries. If you are involved in the collaboration with a low and middle income country, what is your goal in this? Do you equally value the contributions of your low and middle income country partners? Does my work, my project build local capacity? When I publish papers, who are the first and the senior authors? If we get research funding for our project, where does the majority of that research funding go? And ultimately, who is given a voice to speak to funders and priority setters? And then lastly, questions to ask researchers from low and middle income countries. So that's predominantly the people on this call. Unapologetically, I believe that our focus should be on things that make a difference to patients. So the first question I would say, what are the needs of my patients in setting my priorities? And the projects that I do, does it address their needs? The collaborations that I'm involved in, do they build sustainability in my region? Am I committed to a broader goal or just developing my career? If we are involved in collaborations, are we equal partners in that collaboration? Can we change our mindset from a poverty or disadvantage mindset to be on the front foot and believe in what we can do to change our circumstances? And then finally, if we do get the opportunity, are we prepared and are we able to sit in the driver's seat to drive the projects forward? So those are the questions that I would ask. I have some ideas on what the answers are, but I think given that this is a young neurosurgeons forum, it would be better that those questions are posed to you and you come up with the answers for yourself. Thank you very much.
Thank you, Prof. Figaji. Thank you for highlighting all the challenges and the light at the end of the tunnel. So thank you very much. So we'll proceed. If you have any questions, the participants, you can forward it in the chat box. So the next presentation is by Dr. Yemsrach Buzuna from Ethiopia. So Yemsrach is a neurosurgeon who is practicing now at Addis Ababa University.
Sorry, Professor. May I have a comment? Hasha Labadi from Morocco, and I would like to give a comment. It's possible. It's not possible. Don't worry.
Prof. Niger, maybe we can have a question and answer at the end of the session.
Yeah. Not in this session, but of the leaders of North Africa women neurosurgeon, and I would like just to congratulate my friend Figaji for his excellent, really excellent talk, because he point out the elements that it's very, very crucial and important in the evolution of neurosurgery in Africa. And one of them that we did a lot in the future, maybe the two or three decades also, it's about research. The problem in Africa today is to really it's a big burden. It's to, as you intitulate your webinar today, is the AVP sealant. It is the killer sealant. Like
Nadia, maybe we can discuss at the end of the session if it is not an inconvenience for you. Sorry.
Okay, thank you.
With the interest of time.
Just a comment about what happened in Africa, but no worry.
Yeah. So we'll continue with Dr. Msrach's presentation, which is about Ethiopia's experience in neurotrauma registry. So I'll give the floor to Dr. Msrach.
Okay, good evening all. Thank you, Dr. Tsega, for the introduction. As Dr. Tsega said, my name is Msrach, and in the next few minutes, I will have
I'm sorry to interrupt you. There's something happening with your noise in the background. It might be that you're using two devices.
Okay. How about now?
There's still a bit of an echo, but it's a bit better. You can continue.
Okay, thank you. In the next few minutes, I will have a brief talk on the journey of Ethiopia in building neurotrauma registry. This picture speaks a lot about unique features of Ethiopia. And as you know, Ethiopia is the second densely populated African nation following Nigeria. As you can see from this chart, 85 to 90% of the population resides in the rural areas. And the current population pyramid shows over 70% is under 30 years of age. The median age is calculated to be 19.5 years. So traumatic brain injury is a significant risk for morbidities and mortalities with increased risk of trauma severity. Young males are victimized by TBI, and reduction of burden of traumatic brain injury and enhancement of quality of care are going to be achieved by targeted approaches. These approaches include enforcing a robust road safety measures, pre-hospital medical service systems, and consistent trauma registries. So as you can see from this image, it illustrates that assaults, road traffic accidents, and also falling down accidents are the leading mechanisms of TBI in Ethiopia. The major gaps in TBI management were lack of adequate data on magnitude and panorama of neurotrauma to tailor prevention and management, lack of adequate trauma centers, and underdeveloped pre-hospital care, primary trauma care, neurocritical and rehab cares. And for these reasons, two solutions were proposed, and these were the Ethiopian Neurosurgical Outcome Monitoring Database and a multidisciplinary neurotrauma thematic research group. The Ethiopian Neurosurgery Outcome Monitoring Database was initiated with the above premises in October 2012 by the collaborative efforts of Addis Ababa University and University of Bergen, Norway, via the FK project. These 4 Addis Ababa University affiliated hospitals that are demonstrated here were used as study centers. The objectives of the database were to determine the epidemiology and panorama of neurotrauma, to have baseline neurotrauma management, and develop TBI preventive and management guidelines. Developing a high-quality systematic outcome database and enhancing research capacities were also the goals. The methodology used were preparing a pre-tested comprehensive questionnaire to be filled by treating physicians at 4 points of patient management. These were at the time of emergency admission, at the time of surgery, in the wards, and at the time of discharge. All operated elective and emergency patients were included in the study, and data quality was being assured during morning meetings and rounds. The study period was from October 2012 to 2016. Looking at the results, there were a total of 2,078 patients, of which 56% had neurotrauma, and among this, 87% were TBIs, and around 13% were traumatic spinal cord injuries. 88% of the victims were males, and the mean age was 30 years. This table demonstrates the frequency of neurotrauma among the stratified age groups, and as you can see, the productive age group is the most affected one by neurotrauma. Depressed skull fractures accounted for majority of the preoperative diagnosis, followed by epidural hematoma. But when you come to the mortalities, majority of the mortalities were due to epidural hematomas and acute subdural hematomas. The case fatality rate for acute subdural hematoma was higher as compared to the epidural hematomas. Commonest injury mechanisms described were assaults, road traffic accidents, and falls. And tabulation of mechanism of injury and diagnosis revealed majority of the assaults resulted in significant number of depressed skull fractures and epidural hematomas. Severe TBIs accounted for 17% of all the traumatic brain injuries, while a little over 50% of the brain traumas were mild traumatic brain injuries. Tabulation of trauma mechanism and trauma severity demonstrated that 58% of the assaults led to mild traumatic brain injuries as opposed to 14% leading to severe traumatic brain injury. Very significant association was found between admission GCS and mortality, and likewise the presence of polytrauma was a significant predictor for mortality. Issue of sustainability was a challenge due to lack of committed personnel and consistent funding. Missing data and inadequacy of data entry points were major gaps identified. So the proposed solution was establishing electronic neurotrauma registry, which is user-friendly and easy one. And the presence of multiple data entry points on the electronic data registry is outcome assessment. This was witnessed to be helpful in studies like the GENOS study. There was a grant from Addis Ababa University in 2015 for a thematic research planned as a 5-year project, which focuses on neurotrauma, and with the aim of improving quality of TBI care and proposing prevention mechanisms. The research was initiated in 2016. The research team encompassed adult and pediatrics emergency, neuroradiology, neurosurgery, and neurocritical care units, along with the public health professionals. The neurotrauma outcome monitoring database helped us to identify major gaps in traumatic brain injury management and also to outline management guidelines. It also influenced different policy makers like the Ministry of Health. And extents of collaborations and research studies were also boosted up. One example is the collaboration made with the NIHR to conduct the GENOS study. These articles are some of the thematic research outputs, and there was also an opportunity to commence a PhD project on neurotrauma in collaboration with the University of Bergen. So coming to our future prospects are the tasks of developing preventive and management guidelines for TBI. In addition, formulations of neurotrauma data bank and national neurosurgical database registry that can be utilized for generalizability are the ways forward, as several neurosurgical centers are being established currently nowadays in Ethiopia. I thank you all for your attention.
Thank you very much, Dr. Msrach. Thank you for keeping your time. So if you have any questions for Dr. Msrach, you might forward it in the chat box. So we will continue with the next presentation. I will give the floor to Beverly to introduce Dave Manger from Mauritius, Kenya.
Thank you very much. The next speaker is Dave Manger. Dr. Dave Manger has completed his training in Nairobi in Kenya at our WFNS training center, the Kenyatta National Hospital under the University of Nairobi. He becomes the 5th neurosurgeon to train and go back to Mauritius, and Kenya's loss will be Mauritius's gain. Thank you very much, Dave.
Thank you. You can see my presentation, please?
Yes, we can see it.
You can hear me. Thank you very much. So my name is Dr. Dave Manger. I've trained in University of Nairobi. So this paper is about assessment of the prognostic value of Helsinki computer tomography score in severe TBI at Kenyatta National Hospital. My co-authors are Dr. Musau, Dr. Odiambo, and Dr. Mwangi. So this study was conducted at Kenyatta National Hospital, which is one of the largest referral hospitals in East Africa, and is affiliated with the University of Nairobi. So I have no disclosures. So in basic terms, what we have said that traumatic brain injury is considered as a global burden. So it is important to determine a classification that correctly diagnoses it and accurately predicts its outcome. So assessing prognosis is vital for doctors to, especially to make treatment strategies. Though we know that the GCS provide clinical information, it can be error prone in patients with alcoholic intoxication and sedation. And in the early assessment of TBI, we know that we use a computer tomography and millions of CT scans are done. So these CT scans contain some information that can be used to determine prognosis. These other modalities in developed countries, we use biological markers and ICP monitors, which are expensive, but they are not readily available in developing countries. So we know that there are several CT scan scores which have been used. The Marshall CT scan classification since 1991, and it has stood the test of time. There's the Rotterdam score, the Stockholm score, and the Helsinki score. The Helsinki score being the latest in the armamentarium, and it was developed in Finland by Raj et al., where they analyzed 869 patients, and then they what they did from 2009 to 2012, and they found that it was able to predict unfavorable outcome. And like the Rotterdam score, it was easy to calculate and more granular. So what the Helsinki scan score consists of? It consists of the hematoma type, with acute subdural, contusion, extradural, which is given as a points as shown, the hematoma volume. Then we have the interventricular hemorrhage, which is given more consideration of 3 points if it is present. Then the status of the suprasellar cistern. This is the only score that takes in consideration the suprasellar cistern as compared to the Marshall, which takes care of the basal cistern. Because the sum of the scores minus 3 to 14. So why we do the Helsinki score? Telling et al. In Europe, in 2 large trauma centers evaluated the Stockholm and the Helsinki and compared it with the Rotterdam and Marshall and found that the Stockholm and Helsinki outperformed the Rotterdam and Marshall score. Yao et al. In 2017, what they did a retrospective cohort study to determine if the Helsinki was able to predict mortality and unfavorable outcome, and they found that it was significantly associated and it remained an independent predictor of mortality and unfavorable outcome. So this study was done with a broad objective to investigate the prognostic value of the Helsinki City score on the outcome of severe TBI at 6 weeks. So our specific objectives was to establish a baseline, DCS physiological parameters, then to evaluate the predictive value at 6 weeks, and then to determine the correlation between the Helsinki score and the clinical parameters on the outcome of severe TBI. The methodology which was used was a study location was at the Kenyatta National Hospital A&E and Critical Care Unit. It was a prospective observation cohort study which was conducted over 4 months. The patient who met the inclusion criteria was recruited. The data was collected in the initial questionnaire. Initial admission CT scan was calculated, the Helsinki score and clinical parameters, and the patient was followed at 2 weeks and 6 weeks. We evaluated them with the Glasgow outcome score, with the Glasgow outcome score 1, 2, 3 being the unfavorable outcome, and Glasgow outcome score of 4 and 5 being favorable outcomes, and mortality. We also did logistic regression analysis to determine independent predictors, and we also calculated the sensitivity and specificity of the Helsinki score. So I will go to the pertinent results that we got. So the pertinent result that we got for these patients was, as we saw in the first table, as the GCS was increasing from 3 to 8, though it was a severe TBI, we thought that the mortality was decreasing. This was obvious. In 42 patients, we had a mortality of 27 patients. The Helsinki score, as I said previously, it starts from -3 to 14. What we saw was the Helsinki score of 4 had a mortality of 33%, while the Helsinki score of 11 had a mortality of 100%. And most of our patients were from the Helsinki score of 9. We had 15 patients with 66.6% mortality. When we did the correlation analysis of the Glasgow outcome score, Helsinki on the outcome, we found that in terms of unfavorable outcome, there was unfavorable outcome in those with GCS of 3 to 4. But as the Helsinki score increased, unfavorable outcome decreased. But at GCS of 5 to 6, the favorable outcome started increasing up to 7 to 8 with a percentage of 30.43. For the Helsinki score, when we compared it with the Glasgow outcome score at 6 weeks, what we found was when the Helsinki score was low, there was favorable outcome, especially for extradural hematomas. But as from a Helsinki score of 4 up to 9, we saw that the unfavorable outcome decreased, and the favorable outcome started increasing from Helsinki score of 4 up to Helsinki score of 11. So in summary of our results, what we found that 2 weeks interval, the Helsinki was significantly associated with Glasgow outcome score at 6 weeks, and with death with mortality with mortality. What are the Glasgow outcome score? Though it was not associated with which was not statistically significant, it still remains an important predictor of outcome. So we also did what we called for the summary for other variables, and we found that the age was significantly associated with Glasgow outcome score at 6 weeks, and for mortality at 0.02%. Then what we did, we also did correlation analysis for the Helsinki score to calculate the odds ratio, and we find an odds ratio of 9.1 to predict mortality, 5.6 to predict unfavorable outcome. The AUC, the receiver operating characteristic curve analysis, was done to evaluate the performance of the Helsinki score in determining outcome, and we found that it was 0.71 for mortality and 0.69 for unfavorable outcome. In terms of specificity and sensitivity, it was 88.89 88.9% in determining mortality and sensitive at 53%. For unfavorable outcome, it was 81.8% and sensitivity of 55.6%. So majority of our patients were male. The mean age in this study was 33 years old. When we compared to previous local and international study, we found that in our population, the younger population are mostly affected with severe TBI. The mortality rate in this study was 54.3%. Previous studies done locally by Mohan et al. and internationally by Anderson et al. Found the mortality rate to be...
You are left with 1 minute?
Yes, I'm finishing. Yeah. Yes. So the mortality rate ranges from 32 to 49%. The average time of injury or the average time to have a CT scan done from the time of injury was 11.4 hours. This could be due to that we have facilities which lack radiological imaging. The average time to surgery from time of injury was 12 hours. Previous studies internationally showed that if the time for surgery increased by more than 4 hours, it doubles the mortality. This could be due to what we have is we have lack of neurosurgical centers. So although the DCS was not statistically significant for 6 weeks, and mortality, it remains strong. It remains a strong outcome predictor. And how we have seen that the increasing Helsinki concludes his Helsinki score conferred a higher mortality. Hence, in our conclusion, we find that that this study has shown the clinical utility, and hence we think that we need to change a newer computer scoring system, the Helsinki score, as a predictor of outcome in our Kenyan population, in our African population. Thank you.
Thank you, Dr. Thank you for a presentation from promising scoring system to predict outcomes in TBI patients. So we'll proceed to the next presentation.
Okay, I think Dr. Ignatius might be having problems with network. It's a pleasure to introduce the next speaker, Dr. Ana Cristina from Brazil, also originally from Cape Verde. She's a member of the WFNS Young Neurosurgeons Forum, and we're very proud of the research that she's about to present, which is part of her master's thesis. Anna, over to you. I'll stop sharing.
Good afternoon to everyone. First of all, I would like to thank and congratulate the organizers who have been donated and invested their efforts and knowledge in an ideal of progress and neurosurgical education for Africa. They are true inspirations for all of us. To them, all my admiration and respect. I am Ana Cristina. I am from Cape Verde, and I recently graduated neurosurgical trainee in Hospital of Restauração. And I'm very interested in traumatic brain injury. So we will talk about our institutional experience here in Brazil, specifically due to in the compressive craniectomy. So according to WHO, almost 6 million deaths here is due to traumatic injury. And TBI stands out for his high mortality, disability, and healthcare costs. It's one of the main unsolved health problems worldwide. And the definition that we bring in is that it's not an isolated event, but it's a long process of functional disability and substantial financial burden to not only the family, the community, and the government. The WHO estimates that in 2030, it will be the third leading cause of death worldwide. And it's almost higher than a higher burden than infected diseases. In Brazil, more than 1 million people are estimated to suffer a TBI a year. Those 20 to 30% are moderate or severe injuries. But we face with assistant healthcare disparity worldwide, where regions with low resource has been said here in the previous presentations, have high demand, and regions with good structures has low demand. It brings us to to the difficulties that we have today, not only on the guidelines publications, but on the data registrations from those countries, on those regions who has high demand and where those traumas are happening daily. One of the common consequences of the traumatic brain injury is an increased intracranial pressure, who can be effectively controlled by the decompressive craniectomy. Even is an effective alternative, it is still a controversial indication as primary measure, but it's still one of the important procedures in the management of ICP, especially on places with a lack of clinical structure in their contexts. In the Hospital of Restauração, the main criteria to indicate surgery decompression on severe traumatic brain injury is the clinical status, evaluated by the Glasgow Coma Scale at admission, and radiologic findings of the CT scans. As you all know, Brazil is a country with continental dimension, and we are in the northwest region in Pernambuco, and Recife is the capital of Pernambuco, who is a health pole to all the nearest regions. So it receives patients from all around the region and all the states. Has Hospital of Restauração is a reference trauma center. It also has great importance, has training center, reference in national and abroad, and it has still has 830 registered beds, but we still facing with difficulties due to the high demand of patients with basically TBI. The other important thing to characterize is the difficulty to ICU beds. We have only 10 neurological ICU beds, but mostly occupied by elective patients. So trauma patients, in the majority, almost don't get access due to the high demand of those patients. So it's a high demand hospital with almost 3,000 surgeries yearly, and the comprehensive craniectomy are performed about 16 months and 200 a year. So in the time of the studies, we had about 425 decompressive craniectomies. So we aim to characterize those patients, what profile best suit them, and how we are treating them, and how can we improve that care. So we perform a retrospective, descriptive, and observational study using the medical charts and the hospital database to understand their clinical, operative, post-operative feature, and try to associate those characteristics with the prognosis. We understand that a specific protocol with our own local patient, it would fit better our management conduct in those patients. So we found 425 decompressive craniectomy performed in the emergency in the period studied. Those we had 215 due to traumatic events, and we had a significant loss of medical records, mainly due to incomplete data, and we didn't see patients aging under 14 years old or with multi-trauma injuries, surgical in another systems. We found 131 medical charts that were analyzed, And as social demographic features, we found mainly men, young adult men, 90% were men, and the average age was 36-year-old. The range of those age was 40 to 85-year-old. We still have...
You have 2 minutes remaining.
Okay. Some difficulties to point this limit to the old because cultural issues, and the main mechanism of injury was motorcycle vehicles. So we have a very long distance that those patients are referred to, and it's we see that it's not prevail the decentralization of this assistance to the other regions of the state, and it many of these patients were admitted with severe trauma, and acute subdural hematoma and contusion was the most observed CT scan lesions, and they had 3 hours procedure and didn't get access to post-operative unit of intensive care. We have 35% of death, and only when available outcome and the variables, only Glasgow coma scale was associated with bad prognosis. As severe as the TBI has more chances to develop to an unfavorable outcome. So some questions still pops up in the urge to really describe what was really...
Sorry, 1 minute remaining.
Okay, thank you. What really was an early decompressive craniectomy? Is this the timing really a factor of differentiation, the outcome? And how are we treating the different injuries? Are we using different approaches to different injuries, to different pathologies? And as the Neurotrauma Brazil just says, prevention still is the best way to approach. We still hoping to perceive this study with perspective and more robust and accurate structure of type of study, and to contribute to support with this data public health policies to change perspective and implementing prevention mainly on automobilistic accidents. Thank you. Sorry for the time.
Thank you very much, Dr. Anna. So we'll proceed with the next presentation. The next presentation will be by Dr. Lauren Ford.
I am Dr. Lauren Ford. I'm currently a consultant at the Steve Biko Academic Hospital in Victoria. I'm presenting a descriptive study of malnutrition in traumatic brain injury patients that I did while I was still a registrar in the University of the Witwatersrand. And I did the study under guidance of Professor John Omar. I've got no declarations or disclosures. So we all know what a traumatic brain injury is, a direct or indirect injury to the brain itself. And when that happens, there's a overall mortality post-research GCS of less than 8 of 23%. You get the primary and the secondary brain injuries. The last incidence of brain injuries done in South Africa was in 1991, and it showed that there's 360 brain injuries per 100,000 people per year in South Africa. So this leads to us having to provide more adequate calories with excessive, and according to the traumatic brain guidelines, they state that, or their advice is 140% of the basal metabolic rate or expenditure. If we do not give that, there's excessive muscle wasting that goes to severe malnutrition. Malnutrition in itself has a severe mortality rate. This negatively affects the outcomes, and this increases the mortality, what we don't want. So in our study, we had a problem in weighing and measuring bedridden patients. So there was a very good study done in Bangladesh that showed that there is a strong correlation between the mid-upper arm circumference and the BMI for undernourished adults. just for completeness sake, I did include the table that we use, the correlation between the BMI and the mid-upper arm circumference. So what's the risks for malnutrition? The risk factors for malnutrition is multiple comorbidities, emergencies, older patients, non-manual workers, prolonged hospital stay, and the severity of the injury. So what was the problem? We saw at the Chris Hani Baragwanath Hospital in Soweto in Johannesburg that despite giving adequate nutritional support, the TBI patients still waste away. So we wanted to know what was the factors that contribute or result in malnutrition in TBI patients. It was a prospective observational study. Our objective was to look at the socio-demographic and clinical characteristics descriptions, the TBI characteristics on CT brain, and we used the modified Marshall score for that. And then we measured the mid-upper arm circumference on day 1, 10, and 21. And then we also compared the MUAC between the different categories of TBI. It was selective non-random sampling. All patients were included in the study presenting to Baragwanath Hospital with a traumatic brain injury. So what did we find? We had a total of 52 patients, which is a small study. But the majority was African patients. They were male patients and between the ages of 18 and 40 years, which also fits in with all the other related research regarding traumatic brain injury. We only included isolated traumatic brain injury. On average, the hospital stay for this patient was 19 days, and the feeds were started on day 1.5. Full feeds on this day was started on or were achieved on day 3 and 3.6. The average MUAC was 25.8 centimeters, which correlated with a BMI of 27 kilograms per square meter, and that put most of our patients into an overweight category. No patients initially fell into the underweight or malnourished category. 22 patients were fed enterally and 8 orally. Pressure and full ward diet was used. 18 patients had multiple intracranial injuries. And unfortunately, only 14 patients could complete the 3 MUAC measurements on day 1, 10, and 21. So this just is a slide for the gender and the age. So the interesting, what we found was the mechanism of injury. The most patients were assaulted, followed by unknown mechanism of injury, then DVA, fall from height, and then only MVA and gunshot. Our initial GCS was definitely severe. The patients initially fell into the severe category of the GCS between 3 to 8, then a moderate GCS, and then only a mild. And this also correlated with a modified Marshall grading of a grade 5. 47% of the patients fell into the grade 5 group, where we also took them to theatre. Just an interesting slide. So most of the distribution of TBIs was multiple TBIs in one patient with 56%. And of this, most of the multiple injuries were only 2 injuries, followed by 3 injuries, then 4, and then 5. The most common distribution of a single TBI was the subdural hematoma, then the extradural, followed by fractures and subarachnoids. The treatment was 50% between surgery and conservative treatment. So this is just a map of Gauteng province in South Africa. The star that I've put there is more or less where Baragwanath Hospital is. We are the biggest hospital in the Southern Hemisphere and the 3rd biggest hospital in the world. And most of the Gauteng referrals come to us. That is where I drew the red line. So most of our referrals came from our own trauma unit. And then
2 minutes remaining.
Thank you. And then from the other referring hospitals. We had good outcomes in terms of sending the patients home. 50% of patients went home, and unfortunately 25% of our patients demised. In terms of the MUAC, and this is the main thing that I want to get to, there was a general decline in the mid-upper arm circumference from day 1 to day 10 in all 14 patients that we could measure. From day 10 to day 21, we got more random results, depending on whether they were on full feed or still on enteral feeding. But the prevalence of malnutrition was still shown as a 31.25% on day 10 and a 56.25% on day 21. The only two factors that we found that had a association with malnutrition with a p-value of less than 0.001 was the length of hospital stay, and with a p-value of 0.014 was when we started feed. So the later we started the feed, the more malnourished the patients would be. To my knowledge, this is the first research paper from South Africa to analyze the factors that affect malnutrition in post-traumatic brain injury patients. There was some limitations to the study. It was a small sample size. We had to exclude 2 patients due to consent. No dietitians were involved, and bed availability in the state hospitals are always an issue. Thank you.
Thank you very much, Dr. Laura. So we'll proceed to Dr. Jamila. Dr. Jamila, are you ready? Yeah.
Yeah. I will share with you a case of a little girl of neglected growing skull fracture. It was a little girl, 3 months old. She was she had a road traffic car accident with no seat and holding by her mom, and she was ejected from the car, and she was in another hospital with 4 weeks PQ, and 3 months after, this is all what I had it from the parents. The parents did this CT 3D reconstruction. I didn't have any further history and any other symptomatologically. Apart, the child had hemiparesis, left hemiparesis. 12 months later, I saw her. She was in the outpatient clinic at the military hospital where I work. And this is the 3D CT scan reconstruction with a huge defect, bone defect, and clinically she was the child. She was 16 months with a big delayed milestone, standing nearly with the support, no speech, just crying mostly all the time, and the mild motor deficit on the left hemicore. This is the 3D which was bought by the parents with the CT showing a huge defect, bone defect, and malacia. And of course, even showing under the skin, the pulsation under the skin. I took her, I explained to the parents where I'm going to do, and I took her to the OR. This is the image, the photos. The left one is the bone I removed from the skull to try to reconstruct the bone defect, and the other one is what we found, just the arachnoid recovering like a volcano. And the bottom photo on the left is where I did approximately the reconstruction of the dura. And the last one, on the bottom right one, it was what I could did the reconstruction of the bone. But unfortunately, the age didn't give me the opportunity to split the bone and to do the reconstruction properly and to recover all the defects. And with I had a political issue, and as I'm working in military hospital, and I couldn't, just close this one. I had to put by advices to put acrylic, which I didn't want to. And of course, this is just 1 week later, follow up. And I wasn't really happy with the acrylic.
1 minute remaining.
Yeah. And when I lost the patient because the lockdown and the coronavirus, and I saw the baby, I took her to the OR, successfully no infection. I put her under the antibiotic. I did the second reconstruction without acrylic, and thankfully she did very well. And now the child is doing very well. I had this video of her mom just 2 weeks ago. She's dancing. She started talking, and she's very well now. And I hope she will start talking. Thank you very much.
Thank you very much, Dr. Jamila. So with the interest of time, we conclude this session. But before, Prof. Figaji has an information, a PowerPoint to share with us.
Yeah, that's all I wanted to show. My colleague Ursula Rolbink is hosting the intracranial pressure and brain monitoring meeting in 2022. It's a great meeting. It's been around for a long time, always outside of Africa. So this is the first time it'll be in Africa. Much of it is about trauma and hydrocephalus. And it's all about intracranial pressure physiology and brain biochemistry. But it would be great to showcase African research because, as I said, it's the first time on the continent. But just requires a reasonably high level of attention, and we've got more than a year now to get some decent data. Unfortunately, the data tends to be on brain monitoring, which is not always available to everyone. But if you have anything that you think potentially could be showcased here, it'll be great to have you along. And hopefully by then we would have throttled COVID-19 so you can start traveling again. Thanks.